An important announcement. Dr. Geeta Nair from Vaikom has got the Lucky Dip Prize from Ekasi stall, which was selected by Dr. Radhamani. Please don't forget to collect your gift.
A very good morning, all. So, Lakshmi Madam has already said the merits and demerits of the vaginal birth and the cesarean section. As you all know, the morbidities are related to the elective repeat cesarean section. That is the commonest indication for increasing the number of CS rate nowadays, and the morbidity like placenta accreta spectrum and the post-operative morbidity, more hospital stay, all this you can reduce by. And in today's in conversation we'll discuss what can we recommend VBAC, what is our policy. So the vaginal birth after cesarean section, the success rate of 60 to 70% in properly selected patients. So consensus by NICE, ACOG and RCOG that planned VBAC is a clinically safe choice for majority of women with a single previous lower segment cesarean delivery. So it is indicated in singleton pregnancy, 37 or more than that, without a vaginal birth, and it's, you know, the one important predictor for better outcome is that history of previous vaginal birth after cesarean section and cephalic presentation, previous single lower segment cesarean. These are the ideal candidates for VBAC. So I'll ask so what are the factors influencing a successful VBAC, and can a woman with the 2 or more CS can be offered a VBAC? What's your...
Thank you very much, Bindu. Just like Lakshmi Madam was wondering why she was here after the previous lectures, I don't know why we're here after these 3 lectures in a row, but we'll do what we can to encourage people to have a VBAC. I think the successful factors for VBAC certainly would be a previous vaginal delivery, without doubt. And in fact, when you were talking about the Robson categories, I think it's absolutely mandatory, or let's not say mandatory, it's essential to have Robson, because if a woman has previously come in and was in category 1 and had a cesarean section, then you would question whether if she comes in again with another vaginal spontaneous labor, will she manage to deliver vaginally? If she came in and had a cesarean section for breech, for example, without labor, then she may well have a vaginal delivery. And for that, and also, I think it's important for your own statistics to divide category 2 into 2A and 2B, similar to what you said, but to remove the cesarean sections. Because of course you're going to have a high cesarean section rate if you don't have a labor at all. So if you remove your cesareans before delivery, before labor in your primips, then you will have a lower labor section rate, and which is relevant. So you certainly would. You would encourage spontaneous labor to help you, and also I would say it doesn't necessarily have to be 37 weeks and above. You could do preterm as well, because there's no reason, as long as it's spontaneous, you can encourage that. Your second question, I think, is a very interesting question, and in fact, I had a lady recently who had 3 previous cesareans and had changed hospitals because the previous hospital wouldn't allow a vaginal birth. And just like I am extremely pro-choice and say, look, if you want a cesarean section, you can have one, she wanted a vaginal birth, and they said, well, fine, but you do realize I haven't a single clue as to what your chance of rupture is, and you have to accept that. And she did, and she had a vaginal birth successfully. So it is possible, but the answer is no intervention, just like a breech. If it comes naturally, great. If it doesn't,
wait for the spontaneous onset.
Absolutely, yeah. for 2 previous.
Yeah, thank you, sir. So the checklist for a successful VBAC include thorough antenatal counseling with the risk explained. You can use leaflets, or you can use the VBAC checklist for counseling the patient, and proper patient selection is another important factor. Evidence-based, consistent, clear counseling and documentation is very important. Sign informed consent after shared decision making. The decision should come from both sides. And also, whenever you take the consent, you'll have to take the consent for emergency CS also. And this should be conducted in a tertiary care center with a senior obstetrician availability, anesthetist, neonatologist, and blood products should be available. So the contraindications are history of previous uterine rupture, Other contraindications for vaginal delivery like placenta previous CPD, classical C-section and other inverted T or J-type incisions, and previous uterine scar like any abdominal or laparoscopic myomectomy, especially where uterine cavity is breached. So antenatal assessment, I already told you, detailed history of indication for previous years, documentation. You'll have to check the documentation for any scar or surgery during the interdelivery interval. Then second trimester anomaly scan, placenta localization. Of course, you'll have to rule out an adherent placenta. Assess the scar thickness by USG, and you can do a clinical pelvimetry in the third trimester to decide. Anyway, you'll have to take a decision at around 36 weeks whether you will have to keep that patient for a VBAC or you will have to go for a planned elective cesarean section. So I want to ask you, how reliable is the sonological assessment of scar thickness in a case of previous years? Can we predict the risk of scar rupture by doing that?
Well, the incidence of scar dehiscence on a repeat cesarean is 1.5 per thousand anyway. So I think that a sonographic assessment of the scar thickness doesn't always help. You can have a thick scar and you can rupture, or you can have a window and yet still not rupture during labor. So for me, in my practice, I don't recommend it because it is not a good predictive factor.
So you doesn't need to have a...
I don't think you need to do a ultrasound of the myometrial thickness prior to allowing a VBAC.
Okay, sir. So the risk stratification, low risk patient, as you already know, one prior low transverse here, singleton, spontaneous onset of labor is ideally preferable. No need for augmentation. Patients with a prior successful VBAC or a prior successful history of any vaginal delivery. These are the low risk candidates. Then medium risk are two prior cesarean section, any induction of labor or augmentation with oxytocin, and delivery interval is less than 18 months, or undue prolongation of the any stages of labor. So I'm not going to tell about this impending signs and symptoms of scar rupture, as you all know. So how should a woman with the previous years be advised in relation to induction of labor or augmentation of a labor if she's not getting into labor spontaneously? How long we can wait, sir?
In the UK, the standard procedure used to be to offer prostaglandins to VBACs, and that has changed, and it's very eye-opening here to listen and hear that the vast majority of your inductions are Foley catheter, which we are so far behind you. And we are now using Dilapan rods. So I think you can induce your cesarean sections. I perhaps would delay it to not your 39 weeks, but certainly to 41 weeks. And I would definitely use a mechanical over...
We use
a mechanical over prostaglandin. Yeah. That said, the risk of uterine rupture with prostaglandins is 2.4 per thousand, which is the highest. In my practice, I would allow one only, one dose of prostaglandin, and then if she's not ARM-able to give up.
So the recommendation says that prostaglandins are contraindicated, and we are not routinely using that, sir, here.
That's the guideline.
Yeah.
And the guideline is, as they say in England, it's a guideline, not a tram line. You don't have to follow it.
Can we recommend epidural for pain relief in intrapartum management?
Absolutely. I think an epidural is essential. And what you can reassure mothers, because they think that, and staff, that the epidural will mask the rupture. It will not mask the rupture because the rupture goes through to the peritoneum, which is a higher level than the epidural will cover. So, in fact, you say to your mother, have an epidural. If you feel pain, then I need to worry that maybe your scar is tearing.
So what are the challenges in intrapartum monitoring? Can you summarize a few points?
I think that the simple thing about intrapartum monitoring is it is not predictive of uterine rupture. The CTG can remain completely normal if the uterus remains, if the fetus remains in the uterus and the placental circulation is not compromised. To really, the important thing to watch out for is delay in any stage of labor, latent, first or second, and also if the head retracts. If you find on VE that the head is not as low as it was before, that is a big warning sign and you should bail out immediately.
So to conclude, the VBAC should always be planned in a setting having continuous intrapartum monitoring, adequate staff, anesthetist and neonatologist should be available, and the resources should be available for emergency LSCS and neonatal resuscitation, continuous labor monitoring to identify scar dehiscence, labor dystocia or any fetal distress, cut short the second stage of labor, and all said and done, even though our acceptance rates is still less. So individualize the patient, and the patient should be selected properly according to your locally available criteria for VBAC. So that is about a VBAC. Sir, I'm waiting for your concluding remarks, sir.
I thought you were concluding. Absolutely. I think VBAC is safe, and especially if the woman's going back home and is going to be expected to work around the house and what have you, she will be far more mobile, and it is, with eyes open and a well-selected patient, mother, then it is a very good option.